Yeah, sure. Hi, so my presentation is about cardiac physiology, inotropes, and vasopressors. Just kind of brief overview and basic principles. So stroke volume, we all know what that is the amount of blood out of LV cavity with each heartbeat. And then you have the ejection fraction, which is the percentage of blood. And then you have the cardiac output. So it's the amount of blood pushed out per heartbeat per minute. And okay, moving on, there are still some important terms to keep note of. Total peripheral resistance is basically the resistance to blood flow out of LV, which can come from all the peripheral structures. So it can be other organs like end arterioles, especially the end arterioles, which generate the highest amount of resistance. So when you vasoconstrict, it's harder to push the blood through, and you would have a greater resistance to flow. And that's basically your total peripheral resistance being increased. And then you vasodilate, which leads to a fall in the total peripheral resistance. Now, you've also heard of terms like systolic blood pressure, diastolic blood pressure. Very basic terms, we know that. But what we need to know is that systolic blood pressure is mostly determined by the stroke volume. Now, and then the diastolic, which is usually determined by the total peripheral resistance. So if you imagine, like we were tracking the blood pressure, and then the LV is contracting and pushing the blood into the arterial system, right? And you would see that the blood pressure will rise, and the height of that rise will be determined by the stroke volume. So basically, when the LV stops contracting and stops pushing the blood pressure peak at the end will be the stroke volume. And after that, the blood pressure will begin to fall steadily. And the lowest the blood pressure will be determined by the peripheral resistance. So if the peripheral vessels are very vasodilated, then the pressure will fall really low, and then there will be very low diastolic pressure. And if you think about it, that will lead to a decreased mean arterial pressure as well. On the other hand, if the blood vessels are very vasoconstricted, then the diastolic blood pressure will not fall as much, and then you would have a higher diastolic blood pressure, and mean arterial pressure would not drop too much. And I think I will come to it afterwards, like to the significance of this. Now, MAP is basically the average pressure in the arteries during the one cardiac cycle, and it's a better indicator for the perfusion to the vital organs compared to the systolic blood pressure. So next you have the cardiac output, which is very important, and it's mainly determined by these four things. So the preload, afterload, which is similar to systolic vascular resistance, systemic, and then you have contractility and heart rate. So preload is basically the amount of blood loaded into the LV, and the more blood you have in the ventricle, the more stretch you're going to get of the myocardial fibers. And the more stretched they are, the more they're going to contract, which will lead to increased cardiac output. Obviously, you need increased work for this, and that would mean that you would also have an increased oxygen requirement. Now, in many pathologies, you would get increase in the preload. Sorry, decrease in the preload. And to make up for this, you can add volume. So let's say in hemorrhagic shock or any bleeding, you can give the patient blood, RBC, or you can give fluids to maintain the blood pressure, to maintain the preload, so the cardiac output is maintained. Another way is to slow down the heart rate. So when you slow down the heart rate, you have more time for the blood to fill into the LV, and then that means there's more volume pumped out. And lastly, another way is to constrict the veins. So remember that the veins hold a lot of the blood volume, and they also have the alpha-1 receptors in the veins. So if you use sympathomimetics, let's say such as NORAD, it will also have an effect on veins, and it would make them constrict. That means there will be more volume available to the heart, and that would also help maintain the cardiac output. Then you would have the afterload, which is the same thing as systemic vascular resistance, and it's the forces resisting the flow out of the LV. And I think I've mentioned it before already, but the tone of the small arterioles and the precapillary arterioles generate the most resistance. And the heart must squeeze against this pressure to maintain the cardiac output and to open the aortic valve and push the blood in. Now, this can be harder in some situations like high blood pressure, or if you have stiff aortic valve or any kind of obstruction, the cardiac myopathies. So if there is increased afterload, that means there's increased vascular resistance as well. Sorry, decreased vascular resistance. And that means to increase the afterload in these situations, you would have to increase the mean blood pressure. And you can do that by using the vasopressors. So they would increase the vascular resistance. So the size of your vessels, it would decrease and it would maintain the blood pressure. And essentially your mean arterial pressure would not drop too low. Now, more afterload obviously means more work, and it would again increase your oxygen requirements. And then you have the contractility. So it's basically how hard the heart muscle would have to squeeze to pump the blood. And ejection fraction is a very good indicator of this. Now, usually our body has its own sympathetic innervation to heart, so that would maintain the contractility. But in certain pathologies, when your cardiac output drops, let's say cardiogenic shock or even any other types of shocks, you need to increase the contractility. And you can do this by using sympathomimetic drugs like dopamine, dobutamine, adrenaline, or noradrenaline. But I will come to the functions of each later on. So this is basically a curve, and the Frank-Starling curve, showing that as the preload increases, the stroke volume would also increase until obviously the plateau is reached. And as the contractility increases, the stroke volume would also increase. Now, to increase the stroke volume, we can give IV fluids again, or increase the contractility by using the inotropic agents like NORAD, adrenaline, dobutamine. And the last factor is heart rate. So again, it increases cardiac output and maintained by the sympathetic nervous system. Now, basically, heart rate goes along with the contractility. So when you use these inotropic agents, or when the body utilizes the sympathetic nervous system, they would also increase the heart rate at the same time. So increased heart rate would mean increased stroke volume and increased cardiac output eventually. So moving on to inotropes and vasopressors. So as I mentioned before, inotropes basically increase the contractility of the myocytes, and vasopressors increase the systemic vascular resistance. And they're very essential if the MAP is very insufficient. And firstly, you can increase the MAP using the IV fluids, but if you still cannot improve, then you would definitely need the vasopressors to maintain the mean arterial pressure. Because if you think about it, mean arterial pressure is the perfusion to the organs, the mean perfusion. And if that's insufficient, then that would lead to end organ ischemia. And to increase MAP, we can increase either the stroke volume or the heart rate or the systemic vascular resistance. And there are different drugs which can affect each part of this equation. So how do we administer vasopressors and inotropes? Most of them have like continuous IV infusion, which allow for rapid titration to maintain the target MAP. And the half-life of these agents is very short, and they can reach a very stable, steady state in very few minutes, so like 10 minutes or so. But you would need a central venous access due to the risk of adverse effects like tissue ischemia. That's especially common for adrenaline. Next, I think, is just a diagram of all the inotropes affecting each receptors. So just kind of basic overview, but adrenaline it can have an effect on most of the receptors compared to noradrenaline, which is usually acts on the alpha-1 receptors, which is in the peripheral blood vessels. There's also dopamine, which has a variable effect, and then other inotropes such as vasopressin, metronidazole, but I will discuss in the next few slides. So you have noradrenaline. It's very common vasopressin ICU. You would probably see NORAD like literally all the time when a patient requires an inotropic support. It's a very good option for undifferentiated shock. So can be septic shock or a cardiogenic shock or other types of shocks. It's a pure alpha-1 agonist, so it mostly acts on the peripheral blood vessels, causing peripheral vasoconstriction. And when that happens, it would increase the systemic vascular resistance, and your MAP would go up as well. So increased MAP means you actually reversing the hypotension as well at the same time. And as I mentioned before, the veins also have the alpha-1 receptors, so it would increase the CVP, central venous pressure as well, and that would lead to increased preload. But it doesn't have it has very little effect on the beta agonist, beta receptors, so it doesn't have any effect on the contractility or the heart rate, but it can induce a reflex bradycardia. So indications, as I mentioned before, can be septic shock, cardiogenic shock, or post-op hypotension. In some of the studies in septic shock, NORAD has shown to increase the stroke volume and therefore increase the cardiac output by 10 to 15%. It can also increase the renal blood flow and the renal vascular resistance, leading to increased urine output and creatinine clearance as well. In many of the cases, the addition of dobutamine to NORAD and the management of septic shock may be very necessary if the cardiac output is still not maintaining or if the lactic acidosis is not resolving. But dobutamine is a very good inotrope. I'll discuss that next. Then you have adrenaline, which is very non-selective and it can act on most of the adrenoceptors. So it can act on the beta-1, so causing increased inotropy, contractility. It can act on beta-2 receptors, causing bronchodilation. It can also act on alpha-1 receptors, causing the peripheral vasoconstriction. So adrenaline increases the AP by increasing the stroke volume, heart rate, and the systemic vascular resistance, but it can also lead to increased lactate levels. Now, you must have seen adrenaline like most of the times being used for cardiac arrest or anaphylactic shock, but it's also an alternative agent in the management of septic shock if the blood pressure is not responding to noradrenaline or to maintain the cardiac output. Then you have dopamine as well. Dopamine can also have an effect on many receptors, but it depends on the concentration being used. So at low doses, it can stimulate the dopaminergic DA1 and DA2 receptors, and it can cause the vasodilatation in the renal, mesenteric, and the coronary vessels. But despite this, there's no enough evidence that low-dose dopamine can actually prevent the renal failure. And then you have moderate doses of dopamine, which can have a beta-1 effect, which can lead to increased myocardial contractility and heart rate. And then at very high doses, it can have an alpha-1 adrenergic effect, leading to arterial vasoconstriction and blood pressure. So dopamine obviously it's very kind of combined inotrope and vasopressor, and as you've seen, it can affect many different receptors depending on the doses. However, it does produce many adverse effects like tachycardias, cardiac arrhythmias, inhibiting pituitary function. So nowadays it's not very commonly used, and I haven't really encountered dopamine throughout my ICU stay. Next, you have vasopressin. So it's very kind of pure like vasoconstrictor. So acts on the V1 receptor in the vascular smooth muscles of systemic, splanchnic, renal, and coronary circulation. It can also act on other V receptors like V2, V3, V4, but just for this topic, we'll focus on the V1 receptors. And when it does act on V1, it can lead to vasoconstriction of the renal afferent arterioles, leading to increased GFR, along with obviously its main property of being a potent vasoconstrictor. So indication-wise, you would usually use vasopressin in refractory vasodilatory shock. Can be used in septic shock or post-cardiac surgery, vasoplegia. Now, vasopressin has been supported by surviving sepsis guideline for refractory hypertension, but it's not recommended as first-line vasopressor. And most of the time you would be using NORAD. But I think in some places, they do use vasopressin as first line compared to NORAD. But again, it depends on, I think, each trust or hospitals. Next is metraminol. So it's a direct and indirect alpha-1 receptor agonist. Now, this can be administered as a bolus injection and can be used peripherally for short-term use. So usually in patients who have distributive or septic shock, or patients who are very profoundly vasodilated by sedative agents or anesthetic agents. And it's usually used as a temporizing measure. So in that meantime, while we are arranging all the other treatments, such as giving IV fluids or arranging any other infusions, metraminol can be very effective in the meantime to bridge the gap, but also has its own side effects like reflex bradycardia and arrhythmias. And then you have milrinone. So it's an inodilator, so inotrope and a vasodilator at the same time. And how it works is by inhibiting CAMP phosphodiesterase 3. So if you remember, most of these inotropes, they act via G protein coupled receptors, which cause an increase in the CAMP protein. And increased CAMP means eventually leads to increased calcium influx into the muscle, which leads to contractility. So if you inhibit the CAMP phosphodiesterase, that means there will be increased CAMP levels. That means increased calcium influx, and then eventually leading to the inotropic effects and causing increased stroke volume. Now, milrinone can be a titrable infusion, unlike levosimendan, which is another of the inodilator, which I will talk about next. So this milrinone is very titrable infusion, unlike levosimendan, which has very long duration of action. And you'd usually use this in very low cardiac output states. So it's considered first line by some and rarely used by others. It depends. It's very effective in patients receiving beta blockers or with downregulation of cardiac adrenoceptors. So basically in chronic cardiac failure patients. And it has also shown to cause hypotension due to the vasodilation effect that it has, and often needs noradrenaline in conjunction, as in alongside. So yeah. Next, you have levosimendan, which is a very novel kind of inotropic inodilator. It's a calcium sensitizer, and it works. It's an inodilator like milrinone, as I mentioned before. So it can sensitize the cardiac muscles to calcium, and we all know how important calcium is, leading to the contraction of the myocytes. So it maintains the contraction and doesn't impair the diastolic relaxation as well. And it can also cause vasodilation by opening the ATP-sensitive potassium channels in the smooth muscles, eventually leading to reduced preload, afterload, and improved O2 supply to the myocardium, and also increases coronary blood flow and the renal blood flow. There's been a lot of studies and they have shown improvements in the symptoms, especially reducing the BNP in cardiac failure patients. And indications are usually for acute decompensated heart failure, sepsis, post-resuscitation myocardial dysfunction. And as I said before, there's been quite a few studies, and it has shown to decrease arrhythmias, decrease myocardial oxygen consumption, improved right RV function in ARDS, and some other evidence also points to levosimendan, which could be preferable to milrinone in terms of treating patients with cardiogenic shock after cardiac surgery, or for weaning from extracorporeal life support. And it may be superior to dobutamine in terms of short-term survival, especially in patients on beta blockers. However, studies didn't find any long-term survival benefits, but short-term, it could be better than dobutamine. And I think that's it. It's very basic. So yeah, thank you. And if there's any questions.
Thanks a lot, Maulik. Do you have any questions to everyone? Any doubts, any questions that you'd like to ask, or anything you'd like to discuss pertaining to cardiovascular physiology and inotropes?